enzyme, which is the histone deacetylase that the corticosteroids need for their anti-inflammatory effect. And smoking inhibits that histone deacetylase, so it's not really effective in COPD. And then also the inflammation associated with asthma makes the use of corticosteroids more like effective as compared to COPD.
So Matthias, but histone, that explanation didn't come well to me, but you have done well. Note this, and I want you to find out why it's so. In my next lecture, I will ask you why it's so. Matthias, you have done well.
Doc, please, can you talk about the inflammation of the in asthma being eosinophil mediated, and then that for COPD being neutrophil mediated, and so usually the steroids they reduce the eosinophil mediated inflammation, but they don't really affect the neutrophil mediated inflammation. That's why they are not as effective in COPD.
You have a point, but what Matthias said about the histone acetylation, I want you to find out what is that. Basically, let me tell you, basically, COPD patient will not respond to corticosteroids. COPD patient does not respond to corticosteroids. But in asthma, they will respond. So you can use this to differentiate. All that you people were saying, you have a point. Kelvin, you have a point. But I say that for COPD, you have inflammation. Because we have inflammation, we'll be seeing eosinophil also in here. And there's additional mediators that are destructive here. Neutrophil elastin from the macrophages and the neutrophils. You have these mediators, which is not found in asthma. And therefore, they will not cause what? They will not cause destruction. They will only cause inflammation. Therefore, in asthma, you'll be seeing eosinophils. These are not destructive. They are not destructive as compared to the mediators that will be released from the macrophages and the neutrophils. But in terms of inflammation, there's inflammation here and there is also inflammation here. But they have additional destructive mediators that would cause destruction to the intracellular matrix. You get it? You get it, class?
No, please.
Tell me what you don't understand and let me know how I will tackle it.
And please, there are parts about the neutrophil elastase.
Mm-hmm. What don't you understand about it? Mm-hmm.
And please, I'll be happy if you can take that part again.
I am saying that we are talking about asthma, talking about COPD. And I'm saying that these two conditions, linking it to steroids, how do you use steroids to differentiate these two conditions? And I'm saying that normally COPD COPD patient will not respond to steroids, but they will respond to it, to asthma. And I'm also saying that in COPD, there will be inflammation. In asthma, there's also inflammation. There's inflammatory activity going on in COPD and in asthma. But in addition to this inflammation, we have other mediators that are implicated in COPD. And these mediators cause destruction. Those mediators will not be seen in asthma. Those mediators will be seen in COPD. And these mediators, neutrophil elastin, is implicated in COPD. And these neutrophil elastin will cause destruction. So that makes the difference. It's the mediators that are involved in COPD, the mediators that are involved in asthma, that makes the difference. In COPD, they cause destruction. COPD, they cause destruction, plus inflammation. In asthma, they only cause inflammation. In asthma, they only cause inflammation. Is it clear?
Yes, please. Thank you.
Doc,
Mhm.
are we looking at the steroid not affecting the levels of the eosinophil elastase? Then that's why it's not effective for COPD.
Steroids is
Not
not, listen, steroids are not affecting the mediators. Steroids are affecting the effect of the mediators. It's the inflammation. You get what I'm saying?
yes, please.
So steroids, it's like those these mediators has caused inflammation to the lining. And if you don't manage the inflammation, so what happens is that what is causing the release of these mediators? If it's smoking, then you need to think about stopping the smoke. When you are using the steroids, it's going to reduce the inflammation. That is the effect. It's reducing, it's anti-inflammation. It's not anti-mediators. So the effect of the mediators, which is the inflammation, will be reduced. You get it?
Yes, please.
Okay. So I want you to find out why is it that I'll be asking you, Matthias trial, why is it that COPD patient will not normally respond to steroids? They will not normally respond to steroids. They will not respond to steroids because of something. So I want you to find out why COPD patient will not normally respond to steroids, but they will respond to it. I'll be asking you that in my next lecture. And the last one is the inflammation. So let's talk about the inflammation. So when you're talking about COPD, when you're talking about asthma, that's inflammation. You have both disease will cause what? Inflammation. Both disease will cause inflammation, but this inflammation, the pattern of inflammation is different. The pattern of inflammation is different in asthma, different in COPD. And because it's different, in terms of their response to steroids, it's also different. So we have touched in all this. We have touched in all this by saying that in COPD, there's increase in certain kind of these mediators. So we have cells like neutrophils. We have cells like macrophages. We have cells like T lymphocytes. These inflammatory cells will cause the release of inflammatory mediators. These macrophages, neutrophils, T lymphocytes, this will cause inflammatory mediators and cytokines. So the involvement of these, when we're talking about coronary artery disease, we talked about macrophages. I don't know whether you recall, formation of a plaque. Macrophages will release what cytokines. You recall when we were learning about coronary artery disease. Plus, do you recall?
Yes, sir.
Can you tell me one cytokines that are released in the formation of the plaque? Can you tell me one cytokines that are released?
Lot of them.
Come again.
Interleukin 3.
When I was mentioning certain type of cytokines in atherogenesis, in plaque forming within the coronary arteries, I mentioned certain type of cytokines. There are a lot, but in plaque formation, I mentioned.
Okay, you mentioned proliferative growth cells.
I mentioned what? It's what we are learning. I pity for you guys. What you are learning are a lot, but you still have time. We'll be meeting you in a short time, but you still have the whole day to yourself. But please, the things that you are learning. Personally, I'm not going to set any questions outside what I've done with you. Keep on telling you. So I ask you, have you done this topic? Have you done this? I will not. So when you are learning, please don't just brush through. Don't just brush through things. I'm pleading with you guys. The things that you are learning are a lot, but please make sure that if I've done these topics and question comes under these topics, I'll be able to answer. Okay, so we have these inflammatory cells. And these inflammatory cells will release inflammatory mediators and cytokines. And these cytokines, so cytokines, we have leukotriene B4, we have interleukin 8, we have TNF. All these are mediators. And these mediators will cause damage to the lungs, and these will cause pathological changes. This will cause pathological changes. They cause a damage, and it will lead to these pathological changes. COPD is you need to understand. Basically, those infections becomes a secondary, but the main cause as something that would cause the release of these mediators and for inflammatory cells. When you have something which is causing these migration of these inflammatory cells into the airways, these inflammatory cells will cause release of these inflammatory mediators. Some of these inflammatory mediators are more damaging. They can cause destruction to the intracellular matrix of the lungs. This can affect, we have other things, complications that we're talking about. So the airway is damaged, respiratory disease. And when airway is damaged, the simple thing that will affect is the oxygen, exchange of oxygen and carbon dioxide are mostly affected. So that will lead to other things, other complications. So we have tobacco smoking or cigarette smoking. We have proteinase and antiproteinase imbalance. We have oxidative stress. So antioxidants, we have to push in more antioxidant in our system just to offset the oxidative stress. The ROS, the ROS, reactive oxygen species. When you're taking more antioxidants, these reactive oxygen species also cause damage. They cause damage, and I'm hinting you, these will cause cell destruction, and it will promote these ROS or oxidants will promote what we call histone acetylation. I want you to find out what is histone acetylation. I'm just giving you a clue. Histone acetylation. This histone acetylation would oppose the action of steroids. And this would resist the effectiveness of steroids in COPD. This is why, so find out, I'll be asking you, this is why histone acetylation is why steroids are not effective in COPD. So these oxidative stress will cause cell destruction, and they will also promote histone acetylation. They would oxidize biological molecules. They will cause damage to the intracellular matrix. All this will be affected when you have oxidative stress. So these are some of the causes of COPD, some of the causes. I'll be narrow it down to the types. We mentioned that COPD covers a lot of conditions. So we narrow it down to two main conditions, which is which will be the bronchitis, which will be the emphysema. We narrow it down to that. Okay, so now let's talk about the pathophysiology. Pathophysiology. The patho. So based upon what we have learned so far, and can you tell me some of the pathological changes that will be when a patient comes with COPD? Who can tell me some of the pathological changes? Physiological abnormalities or pathological changes. Can you tell me one or two pathological changes or physiological abnormalities that would? In COPD, what are some of the changes? Are you there?
Yes, sir.
Can I hear from you?
There can be airway remodeling. The cells will change from normal columnar to squamous cells.
To what?
Squamous cells.
So if there's a change, how do you call the change? How do you call the change?
Airway remodeling.
It's not airway remodeling. The change is called what? The change is called what? What is metaplasia? Find out what is metaplasia. So these are some of. Find out what is metaplasia and tell me. So these are some of the main pathological changes. And I want to say the main pathological changes. Then I'll break it down into bronchitis, into emphysema. I'll break it down into that. Okay, so we have one of the pathological changes. We have mucus. There's mucus production. And it's not just mucus, there's hypersecretion, mucus hypersecretion. There's hypersecretion of mucus. Hypersecretion of mucus. This one of the pathological changes is hypersecretion. There will be ciliary dysfunction of ciliary dysfunction. So the ciliary bodies, there will be dysfunction of these ciliary bodies. One of the pathological changes that will occur. There could be the airflow limitation. Airflow limitation. I'll be explaining all this. Airflow limitation. And this airflow limitation could be as a result of pulmonary edema, mucosal edema, that would come as a result of inflammation. The inflamed area will be edematous. The airflow limitation could also be as a result of, in asthma, could be as a result of the bronchoconstriction, could be as a result of the mucosa edema. The mucosa edema will come as a result of the inflamed area. But in COPD, there could be airflow limitation. In addition to that, hypermucous secretion could also plaque the area. And that would also block the air. So airflow limitation. And the fourth could be there could be hyperinflation. Hyperinflation of the alveoli sac. Hyperinflation of the alveoli sac. And the next, these are all changes that will occur when a patient comes with COPD. There could be pulmonary hypertension. There could be pulmonary hypertension. And this pulmonary hypertension would lead to right-sided failure, which is termed as the cor pulmonale. Which is termed as the cor pulmonale. Which is termed as the cor pulmonale. And there could be also be gas exchange abnormalities, gas or air exchange or gas exchange abnormalities could also occur in COPD. Because if there's distraction to the alveoli wall as a result of these neutrophil elastin, this distraction would affect gas exchange. That is seen more in emphysema. So these are some of the pathological changes that could occur. Some of the pathological changes. Mucus hypersecretion. More mucus are secreted. And these mucus are secreted as a result of there's proliferation of goblet cells. And this will aid in the secretion of that. This will aid in secretion of that. So these are some of the pathological changes that could occur as a result of COPD. Any question up to this point? Any question?
No, sir.
Okay, so now COPD is basically comes in two major conditions that comes under COPD. Two major conditions. So we have COPD. We have the bronchitis. The bronchitis, and we have emphysema. Emphysema, bronchitis, and emphysema. And each of these will come with its own pathophysiology. These will be coming with its own pathophysiology. So let's take the bronchitis. The bronchitis. Let's take the bronchitis and look at what are some of the pathological changes that will occur You need to understand. I had about 2 years or 3 years ago, I set a full question on bronchitis. I gave this clinical presentation. And the first thing is that I said, based upon this, patient came with A, B, C, D. And based upon this clinical presentation, state what type of COPD is that. So you need to understand COPD. Normally bronchitis affects. Bronchitis does not affect the lungs. It affects the bronchioles and the bronchioles, or the bronchi and the bronchioles. Bronchitis affects those areas. That is the airways. It affects that. And listen, this is what happens. This is what happens. So you are smoking. And I told you that when you smoke or you are pushing in, you are inhaling this smoke. This smoke depends on two things. Depends on the burden. If I say the burden, the amount of the smoke getting into you, or the load getting into you, and the consistency of this getting into the system, the consistency, the amount or the load and the consistency getting into you. This load or this smoke will stimulate the inflammatory cells along the airways. So we have this, the trachea, and you have so we have the bronchioles, we have the bronchi here, we have the trachea, the bronchi here. So these areas will be affected in bronchitis. These areas will be affected in bronchitis. So when you inhale or you smoke, I'm saying the consistency. Do you know what? Those who smoke every day, the person cannot stay without smoking in a day. Every day, person will be smoking. So the burden of smoke, the load, the burden is equal to the load and consistency, the amount getting in and the consistency will stimulate the inflammatory mediators or the inflammatory cells. These inflammatory cells will release inflammatory mediators. And I say that these inflammatory mediators, some of these inflammatory mediators will cause only inflammation. Some of these inflammatory mediators will also cause destruction. So let me ask you this. So the goblet cells, we have the goblet cells. What do you expect to see when you have more smoke getting into the airway? What do you expect? What do you expect to see? What do you expect the goblet cells to do when there's so much?
Doc, please, they increase the amount of mucus they secrete.
So if you have two, would they increase? How much would they increase? What will happen to the goblet cells?
So they'll increase their size.
They increase their size. And what again? And what again? More smoke. So what will happen?
They will increase the rate of the mucus production.
Then what will happen again? We are seeing the increase in size.
Increase in the number of cells.
Increase in the number of cells. Increase in the number. Because if we have two, how much will the two produce? But it's a compensatory mechanism. The moment the system sees that there's so much smoke getting into, and the consistency of these smoke getting into, what the system will do is a compensatory mechanism. Is that there will be cell proliferation. They will be increasing in number and size, such that they can produce more mucus. Do you get it? You get it, class? So these goblet cells would increase in number. These goblet cells will increase in number. We say that there will be goblet cell proliferation. And these will cause mucus production. This will cause excessive mucus production. And that will lead to bronchitis. That will lead to bronchitis. Hold on, somebody's knocking on you. Oh, good. Hello. Hello.
Hello, Doc. Yeah.
So there will be changes. So these are the changes that will occur along the pathway. There will be a bronchi gland hypertrophy. There will be a goblet cell proliferation. And this would increase mucus secretion. There could be changes. There could be changes in the cells, mucosal cells. And there could be squamous metaplasia. Squamous metaplasia. That is what I was asking. I was asking you to find out what is metaplasia. Who find out this metaplasia? When you say metaplasia?
Dr. Sakura, please, I found out that metaplasia is when of the normal cells with other cells that are representative of another part of the body, or it represents another developmental stage of the cell growth entirely.
Good. So, can you tell me one common condition whereby we could have metaplasia? Common conditions that could give us metaplasia.
Cancer just came to mind.
No cancer. One common GIT.
GERD.
GERD. When you have reflux. So esophagus. Esophagus is different from the stomach. So when you have the reflux, there's metaplasia. The cells within, I don't know whether you have done that. You have done GERD.
Yes, please, with Dr. Bobo.
So can you tell me that complication? If you have GERD and it's changing, it's causing metaplasia to the cells within the esophagus or the duodenum.
Barrett's esophagus.
You call it what?
Barrett's esophagus.
Barrett. Good. Barrett. Good. Good. So the same thing happens to this. That there's a squamous metaplasia of the epithelial cells. There's a squamous metaplasia of the epithelial cells. And because we have ciliated bodies, and because we have squamous metaplasia, there's a change of the mucosa. If there's a change in the mucosa, what will happen is that this squamous metaplasia, that is a change in epithelial cells, will also cause destruction to the ciliated bodies. And this will cause ciliated bodies, changes in a ciliated body. And therefore, in bronchitis, this is the whole thing about bronchitis. Bronchitis patient to be coming with productive cough. They'll come with that. Why? Now there's a squamous metaplasia changing in the epithelial cells. And these changes is causing destruction to the ciliated body. And there's proliferation of the goblet cells. There's hypertrophy and there's goblet cells proliferation. And this will cause excessive mucus production. So you are causing excessive mucus production. You are also causing destruction to the ciliated bodies. And therefore, hey, I've locked my door. They are disturbing. So, two things. Now we have ciliated bodies, proliferation, hypertrophy, enlargement. This is causing excessive mucus production. That is chronic bronchitis, causing excessive mucus production. We have squamous metaplasia, the epithelial lining within the bronchioles or the bronchi. There's metaplasia changing, the squamous is changing. And this change will cause destruction to the ciliated bodies. Yes? Please hold on. Hold on. Hello, hello, class.
Hello, Doc.
Okay, so we have, as I said, so this is what happens, pathological changes that happen. So when I was doing the summary, I said that there will be mucus hypersecretion. So in bronchitis, there's mucus hypersecretion as a result of the proliferation of the goblet cells. There's hypertrophy and the proliferation of the goblet cells. That will cause mucus hypersecretion. And I said that there's ciliary dysfunction. Ciliary dysfunction. The ciliated bodies, there'll be dysfunction of the ciliated bodies as a result of the squamous metaplasia, changing of the epithelial cells from one cells to another. So these I haven't zoomed this time. I don't feel comfortable. So one, there's mucus hypersecretion. I'll be asking you this. Ciliary dysfunctioning. So for normal functioning of these, the mucus, the normal function, the mucus would try to make sure that the air getting into it will trap all the dirt or particles within the air. That is the function of the mucus, to trap all the air. So normally the things that we put into our ears just to clear the mucus in there is bad. We put something in our ear just to clear the liquid in there because the liquid trap the air getting into. So these mucus would trap the dirt within the air, any particles within the air will be trapped. And the ciliated bodies would expect to it, will expel. So it will expel these dirt out. This is basically that. So when you are increasing the mucus and you are causing destruction to the ciliated bodies, what will happen is that now there will be accumulation of these mucus. So in bronchitis, there's productive cough in bronchitis. Why? Because there's accumulation of what? Accumulation of the mucus as a result of the goblet cell proliferation. When you say proliferation, it's increasing in number. And there's destruction of the ciliated body. Is it clear to this point? Is it clear to this point?
Yes, Doc.
So take note of this. Bronchitis is coming with different clinical presentation. We haven't got into clinical presentation, have we? But in bronchitis, I'm saying that the load of the smoke getting in will cause persistent irritation. These load will cause persistent irritation. And these will come from the cigar or any other smoke. Because it's causing persistent, this will stimulate the inflammatory cells to move to the site. And these inflammatory cells will release inflammatory mediators. And these inflammatory mediators will now affect, some will cause inflammation, that will cause destruction. So it can cause inflammation to the bronchioles, and this will term as bronchitis, and it can cause inflammation to the alveoli. And it could also have alveolitis and bronchitis. That is for any question for bronchitis. So who can summarize what I've said under bronchitis for me? Okay. I just want to do this for me to know that you have understood what I said. Your response, I don't know.
Sir, sir, please, you said that bronchitis affects the bronchi and then the bronchioles, which is the airway, and mostly the load and then the consistency to matters. The load in terms of the smoke and also the consistency, how frequent that load comes in, will stimulate the inflammatory cells in the bronchi and then the bronchioles. And you spoke about the inflammatory cells, that's the forms of it. The ones that will cause distraction and the one that will not cause distraction. Then you went on to talk about the fact that the smoke consistency, that's it's coming in at consistent intervals, will lead to increased number of goblet cells and also increased size of the goblet cells. Then you went on to talk about the fact that there is also the metaplasia occurring in which there are changes in the cells that's in the mucosa, and this naturally causes a destruction of the ciliated. Yes, sorry, changes in the epithelial cells of the mucosa. Yes,
It's
and
made up of
this would
squamous.
cause
There's a squamous epithelial cells. Good, continue. You're doing well.
So there's changes of the squamous epithelial cells in the mucosa, and this would cause a destruction of the ciliated bodies. So this also leads to the chronic cough. So in all the proliferation and then hypertrophy of the saying something.
Saying that the productive cough, because of so much mucus accumulation.
Yes.
It's good.
Yes.
You did well. Keep it up. So again, what could also happen again is that because of the excess mucus, there could be a plugging of smaller bronchioles. and alveoli with these mucus and particulate matter. Because of this, excessive production of mucus could also plug the smaller bronchioles and alveoli. So this could also affect or cause airflow limitation. And because we have mucus, accumulation of mucus, listen to me. Because we have accumulation of mucus, it could be a good medium for microorganisms to thrive on. That is why if a patient comes with productive cough, it's better to add antibiotics to it. Take note of this. If a patient comes with productive cough, it's better to add antibiotics to it. And therefore, because bronchitis will be coming with so much mucus, excessive mucus buildup within as a result of proliferation and hypertrophy of these goblet cells producing more. And there's a reduction of ciliated bodies that will clear this. That would lead to accumulation of the mucus in the airway. Because of that, because of the accumulation, there could be infection and a good medium for microorganisms to thrive on. The first pathogen that normally comes are viral. The first pathogen that normally affects are viral. Then, if you have virus affecting, then it breaks down the immune system. Then other microorganisms can now invade, like bacteria, can now follow up after the viral infection. And the common pathogens, common bacterial pathogens include common bacterial pathogens. Who can tell me some of the common bacterial pathogens? Some of the common that are in bronchitis, common bacterial pathogens that are implicated in bronchitis. Who can tell me one bacterial pathogen? Some of the bacterial pathogens that are implicated in bronchitis.
Streptococcus pneumonia.
Streptococcus pneumonia, good. Streptococcus pneumonia. Strep pneumonia. What again?
H. influenza.
H. influenzas, good. H. influenzas. H. influenza. What again? Last one. The last one is one.
Oreos.
Moraxella catarrhalis.
Good. So Moraxella catarrhalis. So these are the bacterial pathogens that are implicated in bronchitis. Inflammation of the bronchioles caused by these inflammatory mediators released by these inflammatory cells.
Hello, Dr.
Hello.
Yes, please. Could one of us picked up Oreos and you said AE? It doesn't mean it is wrong.
It's not part.
Okay, thank you.
Streptococcus pneumonia. We have H. influenza, Haemophilus influenza, and we have Moraxella catarrhalis. These are bacteria pathogens that are implicated in bronchitis. Hmm?
Okay.
These are okay. So that is that for bronchitis. So just find out if when do we say patient is having bronchitis? It's not just by saying there's inflammation of the bronchus. When do you say the patient is having bronchitis? So we say a patient is having bronchitis when a patient is having chronic or recurrent cough with sputum. There's chronic or recurrent cough with sputum reduction on most days for at least this thing. There's a chronic or recurrent. So for bronchitis, there's a chronic or recurrent cough with sputum. And these will occur most days for at least 3 months of the year. These recurrent or chronic cough is occurring on most days for at least 3 months of the year. These are first conditions. The patient will be having this on most days, be having these recurrent cough on most days for at least 3 months of the year. During at least 2 so the patient will be having all this for at least 2 consecutive years. For 2 consecutive years. So in most days for at least 3 months, there will be productive cough. And these will be occurring at least for at least 2 consecutive years. When a patient is having this, we say that the patient is having what? Bronchitis. Patient is having bronchitis. Okay, so let's talk about emphysema. So what are some of the changes that will occur in emphysema? What are some of the changes that will occur in emphysema? So what happens in emphysema normally occurs? It could affect the respiratory bronchioles. It also could affect. We're talking about types of emphysema, not today. Talking about types of emphysema. So we talked about emphysema. Changes that occur when a patient comes with emphysema. You say that it affects the respiratory bronchus. It affects also the alveoli. So the alveoli is affected. Alveoli is mostly affected when we are talking about emphysema. Alveoli is most affected. And what happens is that, so when you have this the mediators, the neutrophil elastics, these mediators will cause distraction to the elastic recall. So this is the alveoli. The alveoli could contract and could relax. That is the elastic recall. So what happens is that there's a distraction. The neutrophil elastics will cause distraction to this alveolar wall. So there's this distraction to this alveolar wall. And when that's caused distraction to the alveolar wall. Apart from this, any supporting anything that supports with perimeters attachment, anything that supports the alveolar, there's also distraction. It's also being destroyed by this. And when this happens, when there's destruction of this alveolar or emphysema, what happens is that exchange of gases are affected. Hold on for me. Oh, God. Okay, so hello, class.
Hello, Doc.
So what happens is that now there's distraction to this alveolar wall, which would affect gas exchange. This would affect gas exchange. This would affect the gas exchange. So what will happen is that one, gas exchange will be affected. There's loss of elastic recall, and there's hyperinflation of the lungs. Now gas will be building up within here. Gas will be building up within here. I'll be talking about certain things. I'm saying that there will be distraction to the supporting, I will say, I don't want to use the word organs. Let him say supporting organs. There will also be distraction of supporting organs, and this will distract even vessels. We'll be talking about this later. This will distract vessels. Vessels bringing inwards, bringing in these oxygens. This will distracting these vessels, bringing in this oxygen. So, one, pathological changes that will occur here is that there will be loss of elastic recall. And this loss of elastic recall or distraction of the alveolar wall will disrupt gas exchange. And because of that, there will be a buildup of gas here, and we term it as hyperinflation. Hyperinflation. So this is what will happen. Any question? So let's move on to the clinical manifestation. Clinical manifestation of these. When a patient comes with bronchitis, when a patient comes with emphysema, clinical manifestation. Okay, so okay. Okay, so the clinical manifestation of COP depends on whether a patient comes with bronchitis or a patient comes with emphysema. And there could be also a mixed. You could have a mixture of these. Patient to be having both. But the condition that predominates will be seeing the clinical manifestation. The clinical manifestation. So let's talk about the bronchitis, chronic bronchitis. What are some of the clinical manifestations of chronic bronchitis? Chronic bronchitis, who can tell me, based upon what we have learned, who can tell me some of the clinical manifestation of chronic bronchitis?
Dyspnea.
There could be dyspnea.
Productive cough.
There could be productive cough. Hurry up.
Mucus production.
Mucus production, excessive mucus production. The patient will have excessive mucus production.
The physical also come with fatigue.
Bronchospasm.
There could be bronchospasms that will result in wheezing and dyspnea. Bronchospasms that will result in wheezing and dyspnea. So productive cough, excessive mucus production.
Doc, please questions.
Hello.
Doc, please, with respect to the bronchospasm, please, how would that occur?
Can I ask you a question?
Yeah.
Can I ask you a question? A simple question.
Yes, please.
In asthma, how does bronchospasms occur in asthma?
The minimum.
Why? So you talk about asthma patients, talk about bronchospasms. So all these spasms are due to the mediators, inflammatory mediators. Okay.
You hear myself at the back there.
some disturbances. So in bronchitis, in chronic bronchitis, this patient will come with a bronchospasms. Patients, because of these bronchospasms, and I'm saying that these spasms are due to these inflammatory mediators. This will cause spasms. And these spasms will result to wheezing and dyspnea. It's important to know. There's for chronic bronchitis, patient to be coming with that bronchospasm, patient to be coming with excessive mucus production. So there will be productive cough. So patients who have dyspnea when there's a physical exertion. Patient to be coming with dyspnea when there's a physical exertion. And this is what happens because there's airflow limitation. Because there's airflow limitation. Exchange oxygenated blood getting into the lungs. And carbon dioxide leaving the alveoli. All these exchange will be affected. And therefore, patient to retain more of these carbon dioxide. And they'll be reducing amount of what? Oxygen. Reducing amount of oxygen. This can cause hypoxia. This is seen more in emphysema. This is seen more in emphysema. And there was also bronchitis, you also be seeing this, but it's predominantly seen more in emphysema. And so patients will retain carbon dioxide. And this retention of carbon dioxide would decrease the responsiveness, very important. So the retention of carbon dioxide in bronchitis, the retention of carbon dioxide would decrease the responsiveness of the respiratory center. So there's buildup of carbon dioxide. This buildup of carbon dioxide should stimulate the respiratory center that there's low level of oxygen, such that more oxygen will get in there. But in this situation, there's decreased responsiveness of the respiratory center to the prolonged hypoxemia or hypoxia. So as a result of the retention of oxygen, the retention of carbon dioxide, this retention of carbon dioxide will cause a decrease in responsiveness of the respiratory center to the prolonged hypoxia. And this will lead to cyanosis. So I'm taking it again. There will be retention of carbon dioxide. The retention of carbon dioxide will lead to reduction of the respiratory center responsiveness to this prolonged hypoxia. And this will lead to cyanosis. This will lead to cyanosis, low oxygen in the tissue, hypoxemia. This will lead to that. So there will be cyanosis in chronic bronchitis. There will be cyanosis in chronic bronchitis. Who can tell me what could happen to the chest? What could happen to the chest? What could happen to the chest? Now, there's hypoxia due to what? Small amount of oxygen getting in. What could happen to the chest? Let me link it to this. If a patient goes to the higher altitude where we have low oxygen, where we have low oxygen, what will happen to the hemoglobin? When you have higher altitude where we have low oxygen, what will happen?
The hemoglobin levels will increase.
Hemoglobin levels would increase. So why would the hemoglobin levels increase?
To be able to maximize the amount of oxygen that could be trapped to be used up by the cells.
Good. So this is a compensatory mechanism. You are right. And this is a compensatory mechanism. The same thing applies here. What will happen to the chest diameter? So for bronchitis, because the oxygen getting into the system is low, the chest would enlarge, the diameter, the chest would enlarge. And that will give you a classical barrel chest shape. So there will be a barrel chest. The chest will be enlarged because of such that it could take any amount of oxygen. The patient will be panting for. He said there will be dyspnea, and because of that, the patient will be panting for breath. Any small thing that the patient that's be panting for breath. So the chest will be enlarged. So there's a barrel chest shape. This is a classic part. When a patient comes a barrel chest, and the patient is having what? Having bronchitis. There could be also, because there's accumulation of mucus, there could also be signs of infection. There will be signs of infection. So there will be increase in the volume of the sputum in terms of the thickness. And in terms of the color, there could be color change. It could be yellow or green in color. This could tell you that there's a bacterial infection in there. So there will be infection as a result of the mucus infection. There could be also a barrel chest. And one last thing I want to say about the bronchitis. Bronchitis, clinical manifestation. One last thing I want to talk about it is that for bronchitis, with 10 patients who come with bronchitis at the blue bluter. So bronchitis patients, normally they refer them as a blue bluter. This blue bluter is as a result of this, the patient is able to retain more carbon dioxide. And this retention of carbon dioxide will reduce or decrease the responsiveness of the respiratory center and this will lead to the prolonged hypoxia. So they will develop cyanosis. So we term them as the blue tests. Bronchitis patient we term as the blue tests. Emphysema, clinical manifestation of emphysema patient. So emphysema. So emphysema patients, in terms of the productive cough, is less. In terms of the productive cough, that's minimal or scanty. It's minimal or scanty. The sputum produced is scanty, but that sputum is mucoid. That sputum is mucoid. In emphysema, so we have scanty. When I'm writing, I'm not fast. Scanty, sputum is scanty and mucoid. 2, bacterial infection. Bacterial infection is less. Bacterial infection is less. Bacterial infection is less. It's less. Who can tell me any other clinical manifestation in emphysema based upon your understanding? In terms of dyspnea, how do you compare this? In terms of dyspnea, how do you see? How do you compare?
The dyspnea in emphysema is worse, even at rest.
Even at rest, good. Even at rest. Even at rest. Even at rest. There will be so increase in emphysema even at rest. So there will be that sputum is scanty and there's less bacterial infection. But emphysema patients are referred to as the pink puffer. So dyspnea, there's increase in dyspnea even at rest. Increase in dyspnea, very important because it's affecting the alveoli. And they are called pink puffers. Why? Because the patients would hyperventilate. In emphysema, there's destruction to the exchange. So the patient would, because he or she hyperventilates, there's hyperventilation. Why? To compensate for the hypoxic. The hypoxic state in emphysema is more dangerous, more serious than the hypoxic in bronchitis. So the patient will hyperventilate to compensate for the hypoxia. And they do that by breathing in short puffs. we're talking about these short puffs. So they breathe in short puffs. They will be hyperventilate, then they will breathe in short puffs. So he or she would hyperventilate to compensate for hypoxia by breathing in short puffs. So because of that, they are termed as what? They are termed as the pink puffs, because the patient would appear as pink. The patient would appear as pink. Normally, blacks you will not be seeing, but the white you see. Emphysema patient become as a pink puffs. The skin will appear as pink. The patient will appear as pink. In white, it's obvious, but in black, it's difficult to see this pink. Is that so? These are the major clinical manifestations. Increase in dyspnea, even at rest. Even at rest. In emphysema, even at rest. Any question? Any question? Let me do one last thing. Then I will combine investigation and management tomorrow. That will be end. That will be the end. What are some of the complications? Complications of these COPDs. We talked about bronchitis, talked about emphysema causing distraction to the alveolar wall. Exchange of gases are poor. So there will be difficulty in breathing even at rest. But in bronchitis patient at rest, there won't be dyspnea. But in emphysema, even at rest, there will be dyspnea. Okay, so some of the complications are sleep apnea. There's obstructive sleep apnea. Sleep apnea. One of the complications is that. And what is sleep apnea? You should know this sleep apnea. There could be acute respiratory failure. When you talk about sleep apnea, sleep apnea is simply respiratory disorders characterized by frequent, prolonged pauses in breathing during sleep. And this can disturb the patient. It's a type of respiratory disorder and is characterized by prolonged pauses. So the patient will stop breathing for smaller intervals. Prolonged pauses. There'll be stoppage of breathing during sleep, intermittent and prolonged pauses in breathing during sleep. When a patient comes with that, we say it's sleep apnea. So there could be obstructive sleep apnea. There could also be acute respiratory failure. This acute respiratory failure is simply occurs when the partial oxygen suddenly drops. And when there's a drop suddenly of partial pressure of oxygen, an increase in partial pressure of carbon dioxide, these changes will lead to decrease in pH. These changes will lead to decrease in pH. When we have such a situation whereby there's a sudden drop of oxygen, sudden drop of oxygen, and sudden increase of carbon dioxide. And this is leading to decrease in pH. When you have such a situation, we term it as acute respiratory failure, sudden drop of partial pressure of oxygen, sudden increase of carbon monoxide, carbon dioxide. When you have such a scenario happening, we term it as what? As acute respiratory failure. So there will be obstructive sleep apnea, and there will be acute respiratory failure. So let me end here. I'll finish this with the medication, because we have done some of the medication enhancement. You will not take much time on the medication, because we use mostly the medication in asthma. It's a bit of modification. So let me end here. I'll continue tomorrow and finish.